Hello and welcome back to the part 4. That's the last part of the series of sessions on calcium, a very important element in the body associated with bone health. And also we will see some important adverse effects of very high calcium associated with some clinical conditions. So far we have discussed the calcium homeostasis, how the levels are maintained. We saw what happens at the bone remodeling unit and what's important for proper bone health and what can lead to osteoporosis. In the last part, we saw the 3 important hormones important for maintaining bone health by also promoting bone deposition. And in this part, we will see the drugs and even one of the hormones, calcitonin, which can selectively work as anti-resorptive agents. They just stop the bone resorption. And though they have dubious value, they're not the first line drugs for management of osteoporosis. They are very, very important for controlling life-threatening hypercalcemia. Before going on to studying these drugs and hormone, we will briefly or quickly recap what we saw in the last part. So which are the forms of vitamin D which do not need alpha hydroxylation, 1-alpha hydroxylation in the kidneys? Alpha calcidol and calcitriol, the actual active form of vitamin D. Who should be given these forms of vitamin D? We have the original conventional vitamin D3 available, plus these active forms. So we saw that these forms which do not require the renal activation should be given only to patients who are not capable of this renal activation. So patients with chronic renal failure, low parathormone, low estrogen, which are important for this activation step, only they should be given these active forms of vitamin D. Why must it always be given with calcium? Because if it doesn't have gastrointestinal calcium to restore the serum calcium levels, it will have to resort to bone resorption, mainly as a source of calcium. Which is the analog of parathormone which is being commonly used? It is teriparatide, the first 34 amino acid sequence, and it is more effective and longer acting. Parathormone has got just T half of 2 to 5 minutes, where this has T half of 1 hour. But even then, because of only 1 hour T half, we can use it on a daily basis to give intermittent exposure, which can give us bone deposition as a major effect. The drug which is being developed to control parathyroid hormone levels in hyperparathyroid patients is calcimimetic agent. So like calcium can control the release of parathormone when it is adequate, this drug can control the release of parathormone, so that is used in management of hyperparathyroidism. Estrogen, though, has very important bone protective role, we saw was associated with cancer of breast and endometrium, and so raloxifene, selective estrogen receptor modulator, which gives us the similar actions of estrogen on the bone, but does not cause cancer of breast or endometrium. In fact, protects from breast cancer in the high-risk patients. That is preferred for management of osteoporosis in postmenopausal women. Now let's go on to part 4, that is the anti-resorptive agents, bisphosphonates, calcitonin, and denosumab, and how they are very important in management of hypercalcemia. So bisphosphonates inhibit the bone resorption. How do they do it? They have a very strong affinity for calcium and phosphate, and therefore they get accumulated in the dug up pits where there is acidic zone and lots of calcium and phosphate in the debris. So they bind with this calcium, and as we discussed, the osteoclasts dig it up and then engulf it. So even the bisphosphonates enter the osteoclasts along with this calcium when the debris is being engulfed. And once inside, they damage the cells. So they can damage the ruffled sawtooth cytoskeleton, which is important for digging. They blunt it. And they also increase the rate of death of these osteoclasts. So they reduce the lifespan. So they can have this, exert this anti-resorptive action. And they're probably thought to also prevent activation of osteoclast precursors to active osteoclast. The major action is accumulating in the bone pits at the bone remodeling units, getting engulfed and damaging the osteoclasts and making them die faster. We have several bisphosphonates. The three important ones you need to remember is alendronate, which is still commonly used, not as first choice, but you can still think of it for severe resistant osteoporosis, and pamidronate and zoledronate, the injectable ones, which are very, very important for controlling hypercalcemic state. So prevention and treatment of osteoporosis, they're not the first line drugs today, though they were very popular some time ago. And for hypercalcemic states, to control hypercalcemia, which can be life-threatening, they are very, very important. So BPNs have been developed in batches, like we call them generations of BPNs. So etidronate was the first generation, pamidronate, alendronate, ibandronate, second generation, and risedronate and zoledronate are called as third generation bisphosphonates. With every generation, the potency has increased, the efficacy is increased, and duration of action is increased. So what are these numbers? They indicate the potency. What does it mean? Potency is the amount of drug required for giving you a certain effect. So if potency increases in leaps and bounds, the amount required reduces by that much amount. Okay, so if you can see how we administer it, etidronate had to be given 5 milligrams per kilogram per day. It's less used today. Alendronate, as I said, is the commonly used, amongst these, the first used drug for osteoporosis. Total dose is 5 milligrams. Etidronate was 5 milligrams per kilogram per day. This is total dose 5 milligrams once a day or 30 milligrams once a week. Because it is longer acting as well, you can also afford to give it just once a week. Risedronate, you can see, can be given 35 milligrams once a week or 150 milligrams per month. So you can see the duration is also increasing, whereas zoledronate can be given as an injection just once a year. So the potency is increased, so amount required is reduced, and duration is increased, so frequency of administration is reduced. The bone T-half of these bisphosphonates, almost all of them, is more than 10 years. So earlier it was recommended you don't need to give it beyond 5 years. But then subsequently, some serious adverse effects associated with long-term use of bisphosphonates have come to light, and therefore now they are not recommended to be used for more than 6 years, and now they are not the first or even second line drugs for osteoporosis. So oral bisphosphonate, alendronate, can be given on a daily basis or a weekly basis. Any bisphosphonate given orally has to be given early in the morning on empty stomach with plain water. Because even tea, coffee, milk, even mineral water, fruit juice, everything interferes with its absorption. So to be taken with plain water. Patient has to be instructed that he should not lie down or eat anything for 30 minutes after consuming bisphosphonate. Why? Because we don't want the stomach to be filled up and the bisphosphonate coming in contact with the esophagus. So not to eat or drink anything after for 30 minutes and not to lie down to avoid contact with the esophagus because it can cause severe esophagitis. It also has, as I said, lots of drug interactions. Tea, coffee, fruit juice, mineral water, everything can reduce its absorption, and calcium, iron, antacids. So just because it can cause esophagitis, we do not recommend addition of an antacid with bisphosphonates, which is very commonly done. Adverse effects of oral ingestion, as I said, would be retrosternal pain or heartburn, as patients would complain. It's actually the burning of esophagus, flatulence, and headache. So now it is a third line drug for osteoporosis and not to be used beyond 6 months because we'll see the adverse effect which is found to be associated on long-term use. But it is first line drug for emergency control of hypercalcemia. Of course, the injectable agents are preferred for that. So what is the serious adverse effect on long-term use? On long-term use, they've been found to be associated with osteonecrosis of jaw. This occurs after a dental procedure. If a patient on bisphosphonates underwent some dental procedure, the bone would not heal, and in fact, it went into necrosis. Second adverse effect is atypical fracture of femur, transverse fracture of femur, with trivial trauma or spontaneously, no trauma involved. And this has been observed in 95% of patients out of 394. That's one study reporting it, where 95% of patients developed this atypical femur fracture, transverse fracture of the femur. But most of them had received it almost up to 5 years continuously. And so now we no longer recommend it to be used for 5 years. They're not to be used more than 6 months, if at all they're used for osteoporosis. This fracture is preceded by thigh pain for weeks or months before the actual fracture occurs. So FDA has instituted or included a warning on the label since 2010 that long-term use of bisphosphonates is associated with this. So they're not the first choice drugs or even second choice drugs for osteoporosis. But for bisphosphonates used for controlling hypercalcemia, this warning does not apply. They are very important for controlling hypercalcemia. So these injectable bisphosphonates, pamidronate, zoledronate, they can be used to control hypercalcemia of certain conditions like Paget's disease, where the bone remodeling unit, the functioning at the bone remodeling unit is abnormal, so deposition is not happening as it should. Hypervitaminosis D we saw can cause excessive accumulation of vitamin D and therefore high levels of calcium. But of course, after daily consumption of 40,000 units per day of vitamin D, D3. Hypercalcemia of malignancy, with the increased incidence of malignancy, this is assumed a greater proportion. And this is seen mainly in breast, lung, or myeloma. But even other cancers are associated. But in these cancers, almost 20% of patients develop this hypercalcemia, which, if untreated, can cause death, can be the cause of death instead of cancer in these patients. Why does it happen? Because parathormone resembling like protein, related protein, is released in huge amounts. Osteoclast activating factor is released. There's bone metastasis with release of osteoclast activating factor in huge amounts and formation of calcitriol in huge amounts. So there is severe hypercalcemia, which if not treated can result in death within 6 months. And intravenous bisphosphonates are very effective for controlling this hypercalcemia. However, the limitation is they take 24 to 48 hours to show their effect on calcium levels. But as we will see, calcitonin is acting much faster, but it has its own limitations. So it perfectly fits the requirement of covering this latent period of bisphosphonates. We'll see that immediately after bisphosphonates. Adverse effects associated with injectable bisphosphonates is thrombophlebitis, bone pain, fever, and leukopenia. This is an acute indication, so there's no question of long-term use giving fractures. Coming to calcitonin, it is released from the parafollicular cells of C cells of the thyroid. It works through its own G protein coupled receptors, so surface receptors on osteoclasts and osteoblasts. We've already seen how it reduces resorption by blunting the osteoclast cytoskeleton. It also reduces the reabsorption of calcium as well as phosphate from the proximal tubules. Whether it promotes the bone depositing activity of osteoblasts is still not clear. As anti-resorptive agents, it is less effective than bisphosphonates as well as raloxifene, but it's available as nasal spray, so that's a little more convenient form of administration. Raloxifene is of course orally available, and alendronate is as well available orally, but has lots of adverse effects. So nasal spray is available, but also injectable calcitonin is available, and salmon calcitonin is more potent and longer acting. So calcitonin again has been used for postmenopausal osteoporosis associated with bone pain because it's very effective in controlling bone pain associated with osteoporosis. So there it is used as a nasal spray once a day in alternate nostrils, one day in the left, one day in the right, or it is also available by injectable route, but it is recommended to be used only maximum 4 weeks, not more than that. Why? Because we'll see it has associated with carcinogenic action. So it reduces only vertebral fractures and not other fractures when we use it for prevention or control of osteoporosis. And it is associated with adverse effects of nausea, allergy, tingling of fingers, altered taste sensation, and as I said, carcinogenic on long-term use. And of course, it is costly. So it is again not the first-line drug for management of osteoporosis, used only in resistant osteoporosis, which is becoming really problematic. However, as I said, it can be used in hypercalcemic states as adjuvant to bisphosphonates. So given intramuscularly or intravenously over 6 hours, the action manifests within 4 hours and the peak effect is obtained after 8 hours. However, if we continue to administer, the effect is lost after 48 hours. So it's quick acting, but the effect is lost after 48 hours. So you cannot use it for more than 2 days. And it is less effective than bisphosphonates as its anti-resorptive action. So because it is rapid acting, we can use it to cover the latent period of bisphosphonates. But because it is less effective and it doesn't give persistent effect, we cannot use it as a replacement of bisphosphonates. So it is used as adjuvant to bisphosphonates just for 2 days to cover the latent period of bisphosphonates in management of these hypercalcemic state for rapid control of severe hypercalcemia. Coming to denosumab, which is the latest addition to this armamentarium of anti-resorptive drugs, we've already seen how it was developed based on the knowledge of what's happening at the bone remodeling units. We saw that osteoblasts, after the sufficient bone remodeling unit pit has been dug, they release osteoprotegerins to inactivate the rank ligands released by themselves. And these osteoprotegerins will bind with these ligands and not allow them to activate further osteoclasts because now they don't want any more digging to happen. This denosumab has been developed as an antibody, monoclonal. MAB stands for monoclonal antibody. So many of these biologicals will have the ending MAB, which means they are the monoclonal antibody for some target molecule in the body. So denosumab works like osteoprotegerin and it will bind and inactivate the rank ligands so that osteoclasts cannot be activated and so they cannot dig. So it is a very powerful, again, anti-resorptive agent. So we just saw that it controls osteoclast proliferation by not allowing the rank ligand to bind with the rank receptor and activate the osteoclast. So it's an antibody, monoclonal antibody against rank ligands and acts as anti-resorptive agent. Its effect is greater than bisphosphonates, and in renal impaired patients where bisphosphonates cannot be used, it can be used. It's again available antibody, a protein, so available as injectable agent. So subcutaneous injections can be given every 6 months, and earlier it was recommended not to give beyond 3 to 5 years. And it has been tried in osteoporosis, preventing or controlling osteoporosis in men and women. And it effectively reduced the incidence of vertebral fractures and hip fractures. However, it can also control the bone metastasis in CA breast and CA prostate. However, it is associated with adverse effects like flu-like syndrome. Initially, it can cause a drop in serum calcium because resorption is just stopped. It increases the risk of infections. This is very important to understand. All these biologicals, which are working against or increasing the activity of some endogenous molecules, subsequently end up manifesting with adverse effects because our body is very efficiently designed, and so many of these molecules are multitasking. We identify their role in one situation and try to manipulate it, reduce or increase it, And then it also affects many other conditions where we have not realized that it is really working. And so those adverse effects subsequently manifest. So because these rank ligands also play an important role in immunity, immune response, if you block their action by using denosumab, immune response reduces. And because they're blocking the resorption, they've also been found to be associated with the long-term adverse effects of osteonecrosis of jaw and atypical fracture of femurs. How can you explain this? They're not allowing the bone to be dissolved. And then why should there be these fractures or interference with bone healing after a dental procedure? We discussed that the bone resorption occurring at the bone remodeling unit is an important step for bone rejuvenation, for building new bone. So if resorption is completely blocked, building new bone is also not possible. And therefore the bone would age and become weak. So though it is not actively dissolved, because it is not renewed, we probably see these adverse effects with both these drugs, which are very powerful anti-resorptive agents. So one more adverse effect with denosumab is, suppose you do not want this long-term adverse effect, you decide to use it for a while. One thing is, while in use, it is compromising immunity, and on discontinuation, we've talked about upregulation of receptors. Anything we try to interfere, body is trying to work against it. So if these rank ligands are not allowed to work, then when we suddenly discontinue, there is rapid loss of bone. So whatever we're trying to block is occurring even faster. So again, denosumab, though it has been used and has been found to be effective in osteoporosis and preventing fractures, again, remains an important drug for controlling hypercalcemia. Okay, so that brings us to the end of the series of lectures on calcium. To summarize, we have seen the calcium homeostasis and how drugs favor it or may interfere with it, and where do we need to use calcium as a supplement to diet. Yes, remember, it's always a supplement to diet when required. Dietary calcium is the best calcium. So we must know the sources of dietary calcium and advise them to the patients as well. We saw what happens at the bone remodeling unit, and that helped us to understand what is bone resorption, deposition, and osteoporosis. And we saw the hormones and drugs which help us to avoid osteoporosis or control it. So calcium, vitamin D, raloxifene, and parathormone. We saw the role in prevention and treatment of osteoporosis, and we also saw the other agents which are anti-resorptive, though they are effective in controlling osteoporosis. Why? Their major role, and they are very, very important for this, for controlling hypercalcemia of these hypercalcemic states like Paget's disease or hypercalcemia of malignancy. I cannot resist concluding with the advice that yes, our bone health is in our hands and in our legs. So if you want to avoid osteoporosis, have healthy bones for the lifetime, we need to work for it. Building bone density happens only till the age of 30. But even beyond, the same lifestyle needs to be continued to maintain that bone density, otherwise it will dwindle. So importance of exercise, weight training exercise, exposure to sunlight, and avoiding alcohol, sedentary life, and smoking. So as I just said, the bone bank, the bone density is earned only up to the age of 30, and then we need to maintain it. Though we cannot add, we do need to actively exert to maintain it by a proper lifestyle, and so that we don't need to dissolve this fixed deposit of bone density that we have managed to accumulate up to the 30 years of age. Thank you. I hope this lecture series was useful. Do come back to the site to see more lectures which will be added soon. Thank you.